while we go on. And my name is Sally Grubb, and I'm a board member of the League of Women Voters of Tompkins County. And the League is very pleased to be co-sponsoring this event today, together with Tompkins County Public Library, who really are an excellent community partner. They do an enormous amount, and I encourage you to take advantage of all they offer. I hope we see more people, but it's good to see so many more people. The League of Women Voters of the United States believes that a basic level of quality health care at an affordable cost should be available to all residents. We're here today to learn more about this issue, what we consider to be a healthcare crisis, and what we working together can do about it. The League is a non-partisan organization open to any person 16 years or older, whatever their gender. We neither support nor oppose candidates or political parties at any level of government, but encourage informed and active participation in government, work to increase understanding of major public policy issues, and influence public policy through education, this event, and advocacy. We're always working on vital issues of concern to members of the League and the public. We have nationally researched and agreed positions on important issues from voting rights to natural resources, from the right to abortion to the Equal Rights Amendment, and the importance of health care for all, the subject of today's event. Our speakers today are Rosemary Batt, PhD retired, Rosemary, who's from the ILR School at Cornell, Susan Beckley, manager, and answering questions over Zoom. You can't see him, I'm afraid, but he's there. Richard Gottfried, who is the author of the New York Health Act. So I'm now going to hand over to Dr. Marguerite Uphoff, my child's retired pediatrician. Much loved by many, and I see several hands, much loved by many members of the community from raising such great adults. And she's going to introduce our first speaker. She's struggling with the technology like I do. I now have to turn mine off.
Thank you, Sally. So many of you know me, but for those who don't know me, I'm Marguerite Uphoff. I started practicing pediatrics here in 1970. I came in 70, started practicing in 71 after I finished my residency at Upstate. And I retired when COVID started in 21. So I've seen huge changes in the healthcare system over the 50 years that I practiced. And it was a privilege to be a part of this community and part of the lives of so many of the children and their families in the community. And the reason that I'm out here doing this at this point is because I think the healthcare system really is in crisis. And how many of you think it's in crisis?
Yes.
I guess maybe I could just sit down because I don't have to convince you. But the cost of healthcare is unaffordable for many. It's become more unaffordable as the discontinuation of ACA subsidies and cuts in the HR 1 bill go into effect. 1 million New Yorkers are without health insurance, and for many who have health insurance, the high deductibles, the copays, uncovered services, and out-of-network charges are unaffordable. 66% of the bankruptcies, the personal bankruptcies in the United States are a result of healthcare debt. That's not high. In the U.S.,
We have the best healthcare technology and the most skilled healthcare providers any place in the world. In the US, we spend twice as much money on healthcare as European countries, Canada, or Japan. And against that, we have the highest infant mortality rate, the highest maternity mortality rate among all of the high-income countries. I see some surprised looks. It's not a surprise. This has been going on for a long time. And while many of the other countries are getting better, we're not doing much better. In fact, we're doing worse. And when it comes to longevity, the years of life, the U.S. is shorter than most of the high-income countries. And again, on average, ours is getting worse. And I say on average, and you'll hear more about it. The United States is the only wealthy country that does not provide comprehensive health care for all of its citizens. Many Americans cannot easily get health care when they need it. We have a shortage of physicians, especially family doctors, internists, and pediatricians. Rural areas have the most difficulty recruiting physicians. Insurance companies limit patients' choice by restricting networks. Doctors and nurses are leaving practice. We're hearing the term moral injury more and more as I see my medical feeds and talk to my medical colleagues. Practitioners are frustrated because they cannot provide the quality of care for their patients that they aspire to, that many physicians still, even in this day and age, consider practice a calling.
And I can tell you that it's possible to work many hours and to work hard and not get burned out if what you're doing you feel makes a difference.
And when that's taken away from the practitioners, it isn't worth it. And we're seeing that happening in healthcare now. 1/3 of the money that Americans pay for healthcare goes to administration, including billing multiple different organizations, insurance management, and profit for the insurance companies. Hospitals across the country are having financial difficulty. Several hospitals in New York are considered at risk of closing. Rural hospitals are at highest financial risk. Hospitals must be prepared to take care of patients with life-threatening conditions. A patient suffering from a heart attack or a mother delivering a premature infant is high risk and needs immediate help. Such services that require highly skilled teams and expensive equipment are costly to maintain. In rural areas, the number of patients who need the service does not generate enough reimbursement to cover the cost of maintaining some of these expensive services. It's a problem of high cost and low volume. In urban areas where there is a larger patient volume, that makes a difference. And I've heard people talk about, well, the cost of living is less in rural areas, therefore healthcare should cost less. Healthcare doesn't cost less. Healthcare costs more to be able to provide the quality of service that's needed. And we need to look at each situation differently. Government funding, federal, state, and local account for half of healthcare spending. With cuts in federal funding, the cost of operation for rural hospitals is higher than their reimbursement. The hospitals have to cut expensive services or close. Pediatric patients, as of 2 years ago, are not being admitted to Cuba Medical Center. The low volume of patients is not enough to generate the revenue to maintain a skilled pediatric staff. Pediatricians are sending children who need hospitalizations to Syracuse and Rochester. There are good things and bad things about that. Because of the immunizations that have come about during the time that I practiced, Haemophilus influenza, pneumococcus, those are bacterial infections that were causing pneumonias, meningitis, epiglottitis, otitis media, and so much of that has decreased that the need for hospitalization
for children has decreased. That's made it harder to maintain the skilled services that are necessary to take care of kids when they're sick. So the hospital would have to have pediatric coverage around the clock, and the hospital cannot afford to do that. And the pediatrician cannot admit and leave a child that they think needs 24/7 care. And so they're sending them out. And we can say, well, we just can't afford it. We could say, yeah, that's expensive.
But if we can spend the money that we're spending to bomb and do a lot of other things, we have the money to spend on healthcare. It's how we want to spend it. And I think we can take care of our kids. And I think, and I'm not blaming the hospital, and I'm not blaming the pediatricians. They're all doing a good job. It's a situation that I think we need to be taking more control of. Healthcare should not be regarded as a commodity like soybeans or television sets that investors can profit on. Our country is wealthy enough to provide high quality care. Healthcare should be managed by the community of citizens for whom it provides care. And I think that there's some possibility of accomplishing that with the New York Health Act, which is what you're going to be hearing about. And so with that, I would like to introduce our next speaker, who was actually introduced, Dr. Rosemary Bach. And Rosemary just completed this morning, turned in the last of the edits on a book about healthcare finance. Healthcare and the Age of Finance Capital, Public Funds and Private Gains. So we're hearing from someone who really knows about the situation. So with that, I'll introduce.
Too much. too many bad things.
And Rosemary will make a presentation, and then Susan Beckley will tell us about the New York Health Act. And so many of the people we've talked to don't know much of anything about the New York Health Act, and I think we really have to get that information out. But Susan has spent the last 10 years working with the New York Health Act. She's a small business administrator and knows the New York Health Act inside out. And when we're through with our presentations, we have on Zoom with us Richard Gottfried, who recently retired as a member of the New York State Assembly. Mr. Gottfried wrote the New York Health Act in 1991. It has been modified many, many times since, and he certainly knows it better than anyone else, and he's going to be with us on the Zoom to answer questions at the end of our presentation. So with that, I'll turn this over to Dr. Gottfried.
Can you turn my other little button on?
It's good, I'll turn mine off now.
Okay. And does this work? Ooh, okay. First of all, thank you for coming. It's hard to come at the end of a day and you know, sit and really get serious about something, but this is a really important topic, so I'm glad you all are here. Thanks to Sally for your work and the league for putting it together, for Margaret Reed, for many people. So I'm gonna jump right in. So many of us think about the insurance side of healthcare, right? You know, making sure we get covered, making sure we don't have to pay out of pocket, et cetera. But the other side that I'm looking at is how hospitals, nursing homes, the healthcare industry is making profits off of patients, making extreme profits off of patients. And that's where some of the money is going that Margaret was talking about. We could take care of kids in the rural areas if we had a redistribution of how our healthcare dollars are being spent. So that's what I'm going to talk about. And I'm going to give you the punchline first, which is that the problem is that we have, oops, what happened? There you go. You know, Medicare Act in 1965 is really the gold standard. It provided funding for the elderly, for the disabled, for people with lower incomes. It was a really considered a remarkable social welfare program. But the architects of that program believed firmly that the way to have an efficient healthcare system was to make it a market for healthcare. And so they designed the laws, the rules, and the financing in ways that over time would shift more and more of our healthcare to the market, to for-profit corporations, and that's why we are seeing the expenses, the prices going up and up. So they supported the expansion of a profit-driven system. The government became like a cash cow, and they had very weak regulations. So lots of people were getting into healthcare, not because they had a passion for healthcare, but because they could make money at it. And so I want to show you three kind of trends. So I call it from patients to profits. Now, everybody needs to make a profit if you're a business, but we're talking about profiteering. We're talking about extreme taking wealth out of the system. Okay, so there are three trends that the government rules, and not all intentional, but the upshot has been three trends. The first was, which is to move more and more of our healthcare from public and nonprofit to for-profit enterprises. And they did that, I'll show you in a minute how. The second trend was more corporate control. Now this is what happened is that once you get for-profits moving to get more revenue, more patients, the nonprofit hospitals have to do the same. And so they're in a competition to get more and more patients and to build out massive systems. So that's a second. And then the third one is what I call financial control. And that's the more recent one that many people haven't heard of, but private equity actors from Wall Street actors are involved. And I'll show you what they've been up to too. So there are kind of three moments we're going to look at. So first, privatization in hospitals and nursing homes. So what the rules did is they reimbursed both for-profit and nonprofit health care. But they made the logic that if you're a for-profit hospital, you deserve to get more money from Medicare because you've got to pay your shareholders dividends. So literally in the first 20 years, the for-profit hospitals were reimbursed at higher rates so they could give taxpayer dollars to shareholders. This is a very hidden thing, right? Okay. So that was the logic. That got this huge for-profit system going. So in 20 years, 30% of our hospitals were for-profit and 70% of nursing homes were. And that's when consolidation started, because then they had a lot of money. They could go to Wall Street, they could get stock, equity, and they could build these massive systems. And that launched this first transformation. Okay, then what? So the second story about privatization is Medicare itself. So I'm on Medicare. Whenever we retire, we get to have Medicare. The traditional Medicare, some of you probably know, but there are no prior authorizations. You can choose whatever service provider you want. There's no in-network versus out-of-network, low administrative costs. So it's a system that is viewed as very, very successful. And but the difference is that you still have to get some supplemental insurance because they will not cover things like dental and vision. Okay, the government also decided that you could get your Medicare through a private insurance company. and those plans are called Medicare Advantage. And if you do that, the government reimburses Medicare Advantage plans higher than traditional Medicare because it wants people to switch to a privatized system. Over 50% of our seniors are now in the privatized Medicare plans, not traditional. Well, what does that mean? So the administered by these huge conglomerates, the government pays them higher rates, so they're able to offer things like dental and vision. So many people say, oh, the Medicare Advantage plans are much better. Well, that's because of the way the reimbursement rules have been written. Over 50%, as I said, are now in these plans, and the goal is to have all of us in those plans by 2030. And the Trump administration, they're walking it back now, they would like to, by default, have everyone enrolled in Medicare Advantage as you become eligible for Medicare. Now, you think, okay, is this so bad? Well, what are the Medicare Advantage plans? They require prior authorization. They cover only in-network services. 80% of the market is controlled by 3 conglomerates, United Health Group, Humana, and Aetna, CVS, excuse me. And they've received $25 billion in overpayments since 2018. The government is not requiring them to pay back any of it. What they're able to do is they develop ways of upcoding, developing marketing tools to get people in. They're being sued now out the wazoo because of these practices. They've been denying pre-authorizations. They're really quite scandalous. This is mainstream people, saying this. So if I go back, so what you see is the way that the rules were set up. There are people, both Democrats and Republicans, who believe in the market. They say this is the way we're going to be efficient. But the facts are that it's utterly failed to be efficient because there are ways of gaming the system and people making profits from the ways the rules have been set up. And I'm not saying there are kind of good guys and bad guys. Some of them are bad guys. But there are a lot of people who just say, well, this is the way the system is. And this is the way we have to make money. So we won't go to kind of blaming. There are enough to blame to go around. But OK. So then what's the second thing? The idea of this corporate control. So remember, if you're a for-profit entity, you want to keep growing. You want to keep getting more revenues. You want to keep getting more patients. Then the nonprofits want more. So what has happened is there are horizontal mergers, right? So you keep gobbling up hospitals into bigger and bigger systems. Centralis has now taken over Hugo Medical, but that's a very small system. I don't think we have to worry about that given we still have local control. But we're talking about systems with 100 hospitals. HCA has 300 and 300,000 workers. So then there's vertical integration, and this is what, one day. Okay. Where the doctors are being incorporated into the hospitals, and this was what Marguerite was talking about. 75% of physicians now are either employees or under contract with hospitals or corporations or private equity. I'm going to get to that next. And part of the reason they've had to do that, the expenses, for example, of electronic health record systems, which fail everyone, cause everyone more work. The doctors say they're useless. We get 25 pages and we need 1 sentence in the 25 pages of documentation we get, right? So that's another story. Okay, and then the CEOs are making the decisions and physicians lose autonomy. And this is again what Marguerite was saying, that more and more control is wrested up the ladder into corporate hierarchies. People at the bottom and lose control, both community control and medical control. So that's corporatization, corporate control. That's a kind of second trend we've seen. And then the third trend, well, let me finish here. So consolidation, it leads to monopoly pricing. So 80% of our local markets, and this is from health economists' work, are considered highly concentrated, which means they can charge higher prices. And if a large city, for example, has only 4 hospitals, they have on average 15% higher prices. So that's the kind of economic studies that have been done. So we see our prices go up. Well, why is that happening? Well, the consolidated hospitals are negotiating with the consolidated insurance companies, and the hospitals want to get bigger so they can get better rates from the insurance companies. The insurance companies want to get right? So that kind of bumps up the prices. And then when insurance doesn't cover it, we pay. And then it goes into the kind of medical debt that Margaret was talking about. Okay, but there are no quality improvements. So these studies that look at all the measures of healthcare and patient care, as well as prices, the prices are not giving you better care. So what's happening to those profits, right? Well, CEO pay is through the roof. So the average, you take a system like Montefiore, nonprofit, excellent, CEO is making $15 million a year. The for-profits are making $20 to $25 million a year. So these guys are, equal to the major conglomerates in many other industries. And it's like, well, where is this money coming from? Okay. So now I'm going to go to the third moment, which I'm calling financial control. And this is kind of the most extreme thing that's happened. Has anyone ever heard of private equity? Yeah. Okay. Well, so private equity is just they're financial managers. They raise an investment fund, and then they have a lot of money, other people's money, to spend to buy things. They buy companies, and then they take them private, and they're able to kind of strip assets. It's off the stock market, so it's not seen by the Securities and Exchange Commission. They don't have to abide by rules. There's no transparency, and they can extract wealth. They can do it through cost cutting. They can do it by whatever, selling the real estate. So we have a number of cases of bankruptcies recently where hospitals have gone bankrupt because the private equity firm sold the real estate underneath the hospital, and then the hospital is paying inflated rent for 10 years on property it used to own, with annual escalators in its rent. And that's been driving major bankruptcies in hospitals. Okay, so this is private equity. And so they buy up an entity purely for financial gain. They view them as assets to be bought and sold. And this is where you see a complete divorcing from the care and over here, the financial calculations. This is where the extreme diversion has occurred. They use excessive debt, asset sales, gross undercutting, cost cutting, gross understaffing. And I'll show you a couple things on that. And they try to flip the company in about 5 years to get out. Now, the best analogy I have is they view a hospital as a Lego chip. Okay, and so here's before and here's after. And so you extract wealth by, you unpackage the hospital. Oh, well, I'm going to sell off the lab here. Well, this one wants to buy the lab. And then I'm going to create a national company where I've got all the labs in my pocket. But over here, here's a national staffing company that has all the emergency room staffing over here. And so they're literally unpackaging. And then over here we have ambulatory surgery centers. And there's another person taking that. And so they're fragmenting or unpackaging the healthcare system so they can make money on particular dimensions. That's my best way of kind of explaining it visually. And so then, here's some evidence from very carefully done studies by people, you know, at Harvard or Yale or wherever, but very talented health economists. Private equity-owned hospitals, recent study, have 27% higher falls, 38% more central line infections, 25% more hospital-acquired infections. And that's just looking at the private equity-owned and the for-profits, comparables. And why is this? They grossly understaff. If you grossly understaff, then they're not looking at patients. So that's, you know, that's one study. Here's another. This is of nursing homes. Again, these are, you know, they got data for 15 years in this case, comparing the for-profits to the private equity. And we're not even talking about the nonprofits at this point. Okay, they have 11% higher charges to Medicare, significantly higher ER visits and hospitalizations, meaning their patients are going into the hospitals, substantially lower staffing, and 50% higher use of antipsychotic drugs. What do? They kill people. So they have 11% higher mortality rates. And in this study, this was an equivalent of 23,000 people who died prematurely. And this was like just in the state of New Jersey. So this is private equity. And then this is where their activity in healthcare over the last 25 years. I mean, you see this explosive growth. Now, you know, there was some stuff going on here, but we're talking only in the last decade. It's just gone through the roof. And there's so much money in Wall Street, and a lot of them, they don't know where to place. So they're putting it into healthcare. They've got so much money, they're pouring it into wherever they can. And the government is a cash cow. So this isn't the free market. 60% of their money is coming from the government. So this is not a kind of free market idea where the market is being efficient, right? Okay. And then I'm almost done. This is wrapping up. So you have the first wave of privatization that moved healthcare, not all of it, but a portion, from public and nonprofit into just for-profit hospitals and nursing homes, but also home health, hospice, mental health, et cetera. Then this idea of corporate control, as these for-profits and the nonprofits got more money from the government, they kept expanding in order to get higher revenues, focused on that, and then we lose local control, community control, and then third, financial control of Wall Street actors kind of moving in and buying up. And frankly, the government, it's too weak. There are too many loopholes. The investigators are underfunded, and more so in some administrations than others, obviously. And there are no minimum staffing laws, except in one state in California. So you can just cut staff and cut staff and cut staff. And it's the major issue. It's why the nurses at CUE got organized. It's where most of the nurse unions in the country, nurses have unionized. They're almost 20%. It's one of the highest professions of any in the country, except teachers. And so you're seeing, and doctors too. There are 2,000 doctors that went on strike in the last couple of years. They've unionized. And so it's a crisis in the labor as well. So I'm going to stop there. And that's why we need to return to a publicly owned, controlled system is where I come down. Okay.
Okay?
You might want to move this thing up, no, the other one.
This one.
Can you move that up a little higher?
Is it on? Looking.
Yep.
Yeah, it's on.
He had said that it should be at chest level.
I know, but
Hello? Is that better?
it's working.
Okay. Is that all right? Can it be heard? All right. So,
Just turn it around the other way.
hello? All right, here we go. So after all of that discouraging news, hopefully we have some something hopeful and is in our future. So thank you, Sally and Dr. Uphoff and Rose for your astute observations. And we're going to talk about the New York Health Act as being finished legislation, and it's ready to be brought on the floor of in Albany. And it hopefully will relieve a lot of these difficulties that we're having in this healthcare crisis. So what is the New York Health Act? It's a New York State bill. It's not federal. It will provide health coverage for all New York State residents, regardless of age, ability to pay, or employment status. It will create a single public trust fund through New York State. That's where all the monies will go. And it will pay for all covered health care costs with no copays and deductibles. This is written in the bill. The New York Health Act passed the State Assembly 4 years in a row toward the end of the 2010s. The bill is backed by a majority of New York State Senate and Assembly members. Patients choose their health care providers and cannot be denied coverage. No in and out of network providers. So if you have a physician who feels that you need to see a specialist who does not happen to be in your network and your insurance would not cover those costs, with the New York Health Act, you'll be able to see that specialist and not have to worry about the cost. All healthcare providers continue to be privately or publicly employed as they are now, including all facilities and their employees. There is no government intrusion on providing health care, and no, they're not dictating anything to do with the provision of health care. They simply pay the bills. So the New York Health Act includes all medically necessary services and supplies, primary care, preventative services, prescription drugs with no exclusions. This is huge for so many people. Specialists and hospitalizations. Medically necessary services include mental health, rehab, dental, vision, and hearing, long-term and home care, and skilled nursing. And they cover medically necessary supply costs, walkers, prescription glasses, dentures, hearing aids, wheelchairs, anything that is prescribed as necessary as a medical supply. So what's wrong with our healthcare system now? We have the Affordable Care Act, which reformed the prior system, but doesn't control rising costs. The New York Health Act would control future costs. So the ACA is costly, complex billing, as we've seen, non-universal, doesn't cover everybody, non-comprehensive, oftentimes does not cover dental, hearing, vision, or some other medical services. It's profit-driven, ration healthcare. With New York Health Act will be affordable, simple billing, universal, comprehensive, and accountable to a public board. And there's no rationing of care. So as an illustration, we have here, this is the New York Health Act. This is the ACA. It is 11,000 pages of regulations and rules and stipulations. This is a federal program, covers 50 states and all of those insurances. New York State has 14 insurance companies, so much more modest. As an example, by contrast, this is the New York Health Act. Now, of course, it's going to need to get fleshed out and have rules and regulations, but this are the goals and missions and what is to be covered. What you've seen here is what's included in this act. And so some people say, well, what about a federal system? And what Canada do? This, 8 pages, is the Canadian Health Act. Yes. In total, this is not a summary. The reason being is that all of the provinces had universal health care before it became a federal system. So what this 8 pages is essentially saying, here's how we collect the money, here's how we pay it out, and do what everybody else is doing for universal health care. This bill was introduced in the morning, and I think it was unanimous, but anyway, it was introduced in Parliament in the morning and passed in the afternoon. So we can do better. And in regards to what's going on with people's pocketbooks, this, in regards to 2026, our general inflation is 3%. Our employer coverage, the highest premium increase in 15 years this year, employer coverage has increased 9%. That affects employees and employers. Medicare B went up 10%, highest increase in 4 years. This is in 1 year, since last year. The marketplace, if you're going to get shirts for yourself on the New York State marketplace, including with the subsidies and all of the rest of it, highest increase in 8 years. Out-of-pocket costs. This is your deductibles and copays. So not only are you paying more in premiums, you're paying more out of pocket. This is from 2025 to 2026. Okay, our Churchill moment is here. You can always count on Americans to do the right thing after they've tried everything else. And it seems like we have. So what kind of savings are we looking at for in the event the passage of the New York Health Act takes place? Okay, well, we'll have no agents and brokers fees. We will not have those high administrative costs, up to 30%. Medicare has traditionally been 3 or 4% of overhead. No prior approval for health care. No out-of-network costs. No dividend payouts to shareholders. No drug costs that are not negotiated. And of course, those enormous CEO and upper management salaries, they get incentives, stock options, bonuses, all of that goes away. No yearly health insurance plan negotiations. Everybody, employers as well as employees, if you're on the marketplace, every year you have to renew. And what's happening is that a lot of employers are getting coverage that is less for their employees because of the costs. That means you're going to have higher deductibles and less coverage. And if you stay with that employer or they don't have the coverage you need and you go to the marketplace, you're stuck back with those other kinds of deductibles, copays, and increased premiums. So, and it eliminates endless paperwork for recipients. I mean, we're talking about physician practices and all. One plan. all of the fees are negotiated and provided in this one plan, and you don't have all of these insurance companies and different, there's no couples, family, individual plans, parent-child plans. It's just one plan. Everybody's covered. And prevents those large premium increases, which currently double every 8 years. Okay, so how would it be paid for? Well, currently, the federal funds, the total budget is about $335 billion a year for all of the health coverage for the state. $162.4 billion come from federal funds already. That's Medicare, Medicaid CHIPS, that's the Child Health Insurance Plus programs, and ACA subsidies. Any miscellaneous federal funds would just come into the state. If the federal government decides not to bring it into the state, then the New York Health Act would wrap around whatever is paid for those services and pay the balance. That balance will be paid through a payroll tax, which is progressive and graduated, which is what we have when we pay our income taxes. And the unique and really nice thing about this is that it has a non-payroll tax also. So those people who are living off of capital gains, interest, and dividends will be contributing. And as you can see, they are contributing almost twice as much as the payroll people. Now, this is a study derived from an economic analysis by a professor, Leonard Rodberg, and these are updated figures from 2024. A study is coming out next week. I was trying to get a copy of it for tonight, but they wouldn't give it to me. That is a newer study. So, and it was in peer review, and it's now to be announced on Monday. So we'll see if any of this changes. But there have been a variety of studies done before this. We're in the range anyway. So, and who's running this? Who's going to be in charge of this? Well, we're not going to have those CEOs or upper management. It's state officials and appointees of legislative leaders. It's a 45-member board of trustees appointed by the governor, answerable to New York State residents. So, and the beauty of this also is 31 members of this 35 need to include representatives from these groups. And so these are not private equity people. These are people who are non-physician healthcare workers, such as nurses, people that you would like to be making decisions in regards to your healthcare coverage, public hospitals, representatives of organized labor, such as teachers, healthcare consumer advocacy groups. So those people, those individuals who are not heard from can be heard. And community health workers, all really, really important people deciding about your health care coverage. The other unique and really nice thing about this bill, as far as I was impressed by, is that the board is advised by 6 regional advisory councils. They have to have a minimum of 27 members each with similar representation. So you have the Long Island Advisory Group, the New York City Advisory Group, because all of these regions have their unique needs to be covered. And you have the Hudson Valley, North Country, Central New York, which is us, and Western New York. So these will be advising the board. It's specified in the bill how often they meet and those types of things. But it is indicated that all of these types of representatives will be making up that board and those regional advisory councils. So World War I British Prime Minister David Lloyd George had said, Don't be afraid to take a big leap, because this is a big leap if one is indicated. You can't cross a chasm in small steps. So on that note, for more information, contact the Campaign for New York Health. That's its website. And now Richard Gottfried can take questions.
Could you please say your name again? I didn't.
Oh, Susan Beckley. And if anybody has, I have lengthier presentations as that have a lot more graphs and things. This was a little condensed because of time constraints, but has indications of a lot of what Rosemary Batt was saying in regards to graphs for all of those persons, how they're affected by what's being done to the healthcare system now. So if you want to get in touch with me, please speak with me after we're done here, and I'll give you my email address. If you know of any groups that would like to hear us present, we would be more than willing to do so to get the word out about the New York Health Act. Okay, thank you.
Very simple question.
Can you speak really loudly?
Yes,
Thank you.
very simple question. If a majority of the Senate and a majority of the Assembly say that they are supporting the bill, why haven't they brought it up for a vote and passed it? Who doesn't really support the bill?
I'll let Richard Gottfried, the fellow has been, what was it, 35 years, Dick? I don't know. Let's, can we switch over to Zoom? Okay. Let me have Richard Gottfried answer that one. He was the chair of the Health Committee in the Assembly. Hi, Dan.
Okay, can you hear me?
Yes. Wonderful.
Okay.
Well, yeah, a majority of the members of both houses of the legislature are co-sponsors of the bill. They signed on as co-sponsors of the bill. The problem is that in the last few years, while a lot of the labor movement supports the bill because they want to get healthcare off the bargaining table, the state and local public employee unions, their leaders seem to like the idea of being the ones who deliver health coverage to their members. It's a nice platform for them to run on, I guess. And, you know, in a legislative body in New York with a Democratic majority, if you've got the state and local public employee unions opposing a bill, you know, that's a major constituency. And so even though a majority of both houses are signed on as co-sponsors on the bill, the legislative leadership in both houses in the last several years has not let the bill come to the floor for a vote. And, you know, the answer to that is the bill sponsors have been trying to get the public employee unions to sit down and negotiate or raise their questions and get responses to them. And the other answer is, you know, all of you belong to organizations. You need to help get those organizations to be familiar with the bill and to support the bill and to tell your legislators that, darn it, you want them to put pressure on their leadership to get the bill to the floor and passed.
Thank you.
Put your hand up, yes.
Why are the public unions against it?
Well,
You know, I can't get inside the brains of their leaders, but every argument that I've heard them make is completely bogus. And so I have to assume that, as I said, they like running for re-election in their union by saying, oh, I got you the best health coverage in the world, when in fact the New York Health Act is a dramatically better package than any union or non-union health plan imaginable today. It's not a pretty picture.
Kathy, your hand was up first.
Could you give me an example of one of these public unions?
Teachers.
Oh yeah, they say things like, oh, this will take away collective bargaining. And the answer is, if you've got a choice between having much more comprehensive health coverage guaranteed in law, or every time your union is at the bargaining table, having to either sacrifice the health plan to protect wages and benefits, or sacrifice wages and benefits to protect the health plan, which is better for the members of the union? Having a much better package guaranteed in law is a whole lot better, unless your motive is you want to be the one delivering the benefit to your members. And by the way, I didn't make up the fact that when they're at the bargaining table, they're under pressure to sacrifice either wages or health benefits. The union leaders have said, put that in writing, that it's a major problem today. And these are union leaders who don't support the bill. A lot of union leaders that I've talked to said, for crying out loud, get this bill passed. We want to get health care off the bargaining table so we can focus on wages and benefits. But that's the kind of argument we get against the bill. I think they're bogus.
So I guess which specific local unions in the Ithaca area should be pressuring? Ithaca Teachers Association?
Which ones, Dick? The
Teachers associations are not backing the bill, is that correct?
Correct. New York State United Teachers, the United Federation of Teachers in New York City, CSEA, the Civil Service Employees Association, the Public Employee Federation. Those two unions represent state employees. I don't know what the union is that represents municipal workers in your area. In New York City, it's District Council 37 of the American Federation of State, County, and Municipal Employees. They oppose the bill. On the other hand, the Retail Wholesale Department Store Union, the UAW, the many locals of the communication workers, 1199, the Healthcare Workers Union, New York State Nurses Association, all strongly support the bill.
Yes.
Yeah. When you say the unions support, or say unions oppose the New York Health Act, do they ever put it up to a vote? Are they actually polling their members, or is this just leadership deciding?
As far as I can tell, it's just
the leadership. I don't think they want to have a membership vote. Not that I've ever heard of.
Okay.
You got a question?
Yeah.
Are there other states that have done a version of the New York Health Act that could be helpful in saying to the union leadership, look at the advantages that this state has gotten from it?
no.
There are similar bills in most of the other states that are pending. None of them has become law. And you've got similar opposition, and it depends on the makeup of the local legislature. In New York, the fact that the insurance industry opposes the bill doesn't really count for a lot, considering who's in the majority in the New York legislature. In other states, insurance industry opposition makes a lot more difference. I'd be delighted, I guess, if some other state broke through and passed a bill, and we could say, oh, gee, if Colorado can do it, why not New York? But it hasn't happened yet. And by the way, in Canada, the way they got their universal health coverage was in the 1960s. The province of Saskatchewan created a universal public health coverage system, and then a few other provinces did the same. And then in the 1970s, their national government said, any province that adopts something like Saskatchewan, the national government will pay the bulk of the cost. And in no time, every Canadian province had a plan. We call it the Canadian system. It's actually a dozen provincial plans. And I think that's what'll happen in New York. And, in America, there's a long tradition of good progressive legislation starting at the state level. New York created free public education in the 1780s. And we abolished slavery in New York in 1827. In the early 1900s, we enacted labor laws and worker safety laws. And in the mid 20th century, we enacted civil rights protections long before federal legislation was enacted. The Child Health Insurance Plan began when Minnesota adopted it in the late 80s. We shamelessly copied it in the early 90s. And in the late 90s, under Bill Clinton, the federal government said, if you do any state that does what New York and Minnesota did, we'll pay 2/3 of the cost. And in no time, every state in the union has a child health insurance plan. That's how universal coverage will come to America. I don't think we can count on Washington to do it. Every generation, there's maybe a couple of years when Washington has a moment of enlightenment. I don't see one of those moments coming anytime soon.
I was going to ask about the criticism that I have heard by people who are against this, that we will have a backlog like Canada, that they're afraid the Canadian system supposedly doesn't have enough doctors, or you have to wait for months and months to get appointments. What have you heard about that as a criticism?
Well, I've heard that concern raised. And, today, people I talk to will say, I'm supposed to get this or that procedure, and I was told I have to wait 6 months for it. Part of the problem that we have today is that our doctors spend a huge chunk of time every week, instead of providing healthcare to patients, being on the phone or on the computer fighting with insurance companies. They spend 4 times as much time and money on that kind of administrative garbage as doctors in Canada. And if we can get that off their plate, they'll have a whole lot more time to take care of a whole lot more health care for me and you. And they're going to be well paid, because the bill guarantees that they will be paid a lot more than Medicare or Medicaid now pays. Hospitals and others charge, people with insurance a lot more, because they need to cross-subsidize the care that they provide to people on Medicare and Medicaid, or people with no health coverage. All that goes out the window with the New York Health Act. They will be fully and fairly paid to take care of each and every one of us. And what will help guarantee that is that the governor and every member of the legislature and their families and their friends and their campaign contributors will all be covered by the New York Health Act. And they will have a powerful interest in making sure that the program treats them and their healthcare providers as best as is possible. And 20 million of the rest of us get to be passengers on that same boat.
Thank you. Brian, I think you had a question come in.
Yes, from the online chat. would Medicare recipients continue to make monthly Part B payments?
People who are on Medicare
will continue to get every benefit and right that they have under Medicare. I mean, the bill explicitly says that. I mean, New York couldn't take away your Medicare rights anyway. That's federal law. But the bill does say that it will fill all the gaps in Medicare and Medicaid. And so, nobody in New York will need Medigap coverage. Nobody on Medicare in New York will have to worry about copays or deductibles or additional charges. The New York Health Act will cover all that. And by the way, many of us today have that kind of protection. I'm a retired state employee as a retired legislator. If I go to the doctor and let's say the bill is, $800, my Medicare is going to pay, pick a number, like $500. My retiree health benefits will pay about $300 or $400 on top of that. I pay about a $25 copay. By the way, to all of you New York taxpayers, thank you very much for my retiree health benefits. But, we've got precedent in New York for a state program to fill all the gaps in Medicare. And under the New York Health Act, that will be available to every Medicare enrollee in New York State.
Dick, I think that they were asking also about the Medicare premiums that are typically deducted from your Social Security or you pay to Washington each month. And so there are no premiums associated.
Under the Medicare law, a state can choose to pay for people's Medicare premiums and copays, et cetera. It's called the low income beneficiary program, but it's not really limited to low income beneficiaries. The state can set the eligibility level, at infinity if it wants to, as long as it pays the cost. And that's exactly what the New York Health Act will do. So yeah, nobody will have to pay, no one on Medicare will have to pay premiums, copays, deductibles, et cetera. That will all be paid by the New York Health Act.
More questions from the chat, Brian?
Yes, there are two questions from the chat that are better served for Dr. Uphoff. They are both in the same vein, if you will. And they are, why is our local community not hearing in the media about the understaffing and policy not to admit children in our local hospitals, followed by, does a child whose appendix is in immediate danger of bursting have to risk an ambulance ride to Syracuse, Rochester, or Sayre to be treated?
The situation is more complicated than just pediatricians do or don't admit. The emergency room is staffed with emergency room physicians who are capable of making judgments about how a particular emergency should be treated, and they're very capable of handling something like an acute appendix. And what is problematic is that we don't have a staff of pediatric trained emergency room physicians. We don't have a pediatrician around the clock in the hospital. When pediatric care is required in the hospital, it is usually because that child can't be cared for at home. And there has to be a staff that is familiar with children, is trained, has special skills for taking care of the children. It's not just one person, it's a whole team. And that's expensive to maintain. And given the decrease in the number of pediatric admissions, it's a very expensive thing to have. Before I retired in 2021, there was discussion about having a unit at the hospital that would provide both three things really: emergency care, urgent walk-in care, and short stay care, which would be a lower level of pediatric care, but it would be enough volume to support having a pediatrician and a staff at the hospital. It would not make money for the hospital. It would probably lose money for the hospital. Most of the physicians in town are paid by CMA or the hospital. They're employed physicians. The pediatricians are not. They're independent. So the hospital doesn't pay them. And for all the years that I ran out to the hospital in the middle of the night, there was no special pay for that. And frankly, many of the patients who came in as emergency patients in the middle of the night were the ones who were less likely to be in a position to pay. And given the situation now, the pediatricians don't have the support at the hospital that they need to care for patients. They can't stay there all night. So it's a difficult situation to solve. It isn't because anybody is doing the right or the wrong thing. And they're doing the best they can to provide the best care that they can. Could it be better? I honestly think it could be, but I think it would be difficult to arrange it.
Is yours a follow-up question or yours?
Yes. Yes, it's a follow-up. So this is sort of half a comment, but last time I went to Hugo Medical Center at night, we ended up walking out without seeing a doctor because as we turned out, it looked like we were the 2,000th person to have done that. And I finally went up and I went, what is going on with the staffing here? And they told me that at night they had one doctor present and 0 doctors on call. So there was one doctor, no matter how many people who came in, everyone was just queued behind that one doctor. I don't think it's possible to have a functional emergency room if they don't have a way to get more doctors present when there are more people showing up. And they don't. And they could hire more people. The CEO of Hugo Medical Center collects $4 million a year. You could hire an additional doctor for part of that, but they don't. And combined with a whole bunch of other things that have been similar at the emergency room, you read about the guy who died in the waiting room a few years back. I don't know if they fixed it, but I read a review of them just listing this stuff off and saying the emergency room is understaffed at night. I had called their PR department. They said, we don't like that you wrote a bad review. You want to talk to our PR department. I said, I'd be happy to talk with someone who had authority to change staffing about whether you want to change policy. They said, no, we won't let you talk to anybody who could actually fix anything. We just want you to talk to the PR people. I said, no, thank you. I added that to my Google review. And I told everybody in my family, if I am bleeding out, rush me to Syracuse. So there is something very, very wrong with this hospital, and I think it is understaffing. Now, I don't know if they've fixed that since then, because that was a couple of years ago, but I've heard nothing to indicate that they have. So this is just a sort of a comment about the general staffing issue.
I think I've heard lots of comments about that. I am no longer practicing at the hospital, and I'm not, I was actually president of the medical staff 2 different times during my career, but I've never been a member of the hospital board. And I think the question you raise really is, could the community have any influence on how the hospital is operated? And I think that's a good question for Mr. Gottfried. Will the New York Health Act actually provide more input for communities to have some say in how the health care is delivered in their regions? It seems to me that with 6 regions and with community representation in those regions, there should be some ability to influence the kind of health care that's provided.
Well, the New York Health Act does provide for a series of regional advisory councils to be created, rooted in each region, both healthcare people and rank and file population. The bill is focused on how we pay for healthcare rather than how our hospitals are managed or run. I mean, there are bills in the legislature that would provide for more community input into overseeing how our hospitals are run. But one connection between the New York Health Act and inadequate services in hospitals is a couple of things. Number one, hospitals are severely underpaid by Medicare and Medicaid and by what in the industry are sometimes called self-pay patients. People in the healthcare world know that that means that they don't pay. And that's one point. And secondly, we always read stories about major hospitals that have more billing clerks than they have nurses. And you've got, doctors that have to spend a whole chunk of the time that they ought to be spending taking care of patients. And instead they're fighting to try to get their patient's insurance company to pay for the care. With the New York Health Act, hospitals won't have to spend so much money on billing clerks, number one. And number two, doctors will not have to spend so much time away from patient care fighting with insurance companies. And that's going to improve access and quality of healthcare for all of us.
Follow-up question. What will we do with all the laid off billing clerks who lose their jobs?
That's a good question. And by the way, I don't know if any of you have sympathy for the people who work for the health insurance companies whose job is to say no to your doctor. But, there are about 23,000 people who work in the health insurance industry in New York State. And I don't know how many billing clerks there are, but several economic analyses of the New York Health Act and similar proposals in other states and national proposals by independent consulting firms like the Rand Corporation and by academic experts all conclude that the New York Health Act will put so much money back in the pockets of consumers and employers and taxpayers that it will generate 150 to 200,000 new jobs just in the state of New York. So the billing clerks will have a shot at getting any number of those 150 to 200,000 new jobs that will be created thanks to the New York Health Act. And they'll be doing, the work that they're doing today. It's not their fault that the work they do should not have to be done. But they will be available to do any number of other jobs that actually contribute to the welfare of New Yorkers. So,
Okay, a couple more questions, Dick, please.
Yeah.
You had a question.
Oh, I was just saying, Medicare. Okay, so instead of paying, $500 every 3 months or whatever, that money to Medicare, that money would go to New York State under this act, or my Medicare tax money would, I guess I'm still a little unclear about how the Medicare.
No, the New York Health Act will be funded
by a progressively graduated tax, in other words, based on ability to pay on payroll income and non-payroll income that is currently subject to the New York State income tax, like dividends and capital gains. That money, thanks to all the savings with the New York Health Act, a good chunk of that money will then be available to be used to pay for all the things that Medicare enrollees now have to pay out of pocket.
Thank you.
And I can help that, after we're done here, okay?
And then we had
Just a couple more questions, Dick, if that's
one
okay?
here and
Yeah.
Nancy, and then can we take the third?
We have three
Three.
to finish up.
Yeah. Quick, yeah.
Hi, Dick. I used to be a constituent, and I'm from Toronto. So, the New York State health is broken in many ways. Will the Health Act actually help fix that?
I'm sorry,
What
what
is
is
it
it
that
that
you
you
said
said
is
is
broken?
broken?
New York State of Health.
Oh, yeah. I mean, an awful lot of the problems in our healthcare system all trace back to, inadequate funding for a lot of people, and to the fact that for most New Yorkers, their health coverage is controlled by for-profit corporations that take money that ought to be going for healthcare or going back into your pocket and use it on bureaucracy to stand in the way of your healthcare, and marketing and executive salaries and profit, and a whole host of problems in our healthcare system all stem from that fundamental reality.
Another question?
Nancy.
I'll answer my.
What organized or individual efforts would actually make a difference in getting the Health Act passed in New York State? I mean, you did mention it was being held up by union bosses, and that leaves me wondering, is there anything that people can do to help get this passed?
Sure, and as I said,
I'm sure you're all part of various organizations. Get those organizations informed about the New York Health Act. Get them involved in campaigning for it. And you and everybody you can get to do so needs to be contacting your assembly member and state senator to raise their voices to demand that this bill come to the floor and be enacted. That's how we get major change for the public in New York.
Quick question about.
by the way, let me just,
If you can jot this down, there's an organization called the Campaign for New York Health. Their website is nyhcampaign.org, nyhcampaign.org, or you can just Google Campaign for New York.
We have it, Dick.
Okay.
Yeah, they're informed.
They can help you get involved.
So.
The quick question that I
It was New Yorkers who would seek some treatment outside of the state, say going to Boston or going to the Mayo Clinic or wherever they might need additional care. How would this legislation address paying for services that happen outside of the state?
If you're covered by the New York Health Act and you need health care because you are temporarily out of state, the New York Health Act will pay for it. And when I say temporarily out of state, that means if you're hiking in the Grand Canyon and you break your ankle, or if you spend a few months of a year in Florida or Arizona, or if you live a few miles north of the Pennsylvania border and your local doctor or the nearest hospital is across the border in Pennsylvania, the New York Health Act will pay for that care.
All right.
Question.
The rest of the question. You addressed the being out of state for travel. However, suppose you choose a medical team to provide you with, I'll call it specialty care, like at the Cleveland Clinic or.
Absolutely, the bill
Language says if there is, if there is a medical justification for going out of state, like if the Cleveland Clinic is the, most convenient place for you to go for whatever, procedure is involved, the New York Health Act will pay for that.
It's not convenience, it's whether you choose the specialist out of state. You go to Boston or Minnesota.
It would be covered. It would be covered by the New York Health Act, yes.
As long as you remain a resident of New York State. If you move out of New York, then you lose your New York health coverage.
Well, if you have children in the Ithaca public schools and you move to Pennsylvania, they're not going to get to go to Ithaca's public schools anymore, right?
There's one quick question here.
Okay, last question, Dick.
Sure. If the Assembly and the Senate, New York Senate, were to bring these to the floor and pass them, what are the chances that Hochul would sign it?
Good question, but we don't know. Like every governor I served with, and I was in the legislature going back to Rockefeller, when it comes to significant legislation or even minor legislation, governors generally say, I'm not going to comment on it. If it passes both houses and is on my desk, we'll talk about it. So Governor Hochul, not surprisingly, has not said she's for it or against it. I'm sure she and people in the health department will want changes in the bill, I imagine. We do that, the legislature does that all the time.
Okay. Thank you, Dick.
Thank you.
Thank you.
Please applause. Appreciate you being here. And
Well, thank
to
you
the
all.
League of Women Voters. Yes, thank you to the League of Women Voters for sponsoring this, and Tompkins County Public Library. Very nice, Dick. And to Rosemary.
Thank you.
Finally, the recording, the YouTube recording will be on the library YouTube. Okay.